This morning presented the study of 52 patients who were transplant-eligible patients with myeloma. The patients received 4 cycles of Elotuzumab, Lenalidomide, Dexamethasone induction, followed by transplantation. The patients then received 4 cycles of consolidation with Elotuzumab, Lenalidomide, and Dexamethasone, and then the patients had 2 years of maintenance with the same 3 drugs, although the steroids were only given on the day of Elotuzumab, which was the first day of the cycle. So what we saw, the primary objective of the study was to see if this combination, triplet combination, was sufficient to take patients to transplant, and it's considered a transplant feasibility rate. And we saw, unfortunately, we did not meet our primary endpoint. We were expecting to have patients, about 80% of the patients progress to transplant, and we only saw 69%. But what was interesting otherwise is this was a very well-tolerated therapy. One of the reasons we decided to initiate the study is that when you use proteasome inhibition, which we did not use in this study, a lot of patients get peripheral neuropathy and have cardiotoxicity. And so the hope was to actually come up with a regimen that was safer. So for all patients, we feel this is not a good combination. But when you actually look at patients in different risk kind of groups, there's a high-risk group that was identified, and then there's a standard risk that's also identified. The standard risk patients actually did very well. And so thus far, with a median follow-up of 20 months, we're seeing that the PFS is close to 90%, and overall survival 94%. And so we're hopeful that at least for this part of the population, that this may be a less toxic regimen, especially in someone who may already have peripheral neuropathy from their myeloma or other comorbidities where you don't want to add any further toxicity. This may be a very active agent.